My name is Sheldon Litwin. I'm a professor of cardiology at the Medical University of South Carolina in Charleston, South Carolina.
I'm Rajiv Mohan. I'm a heart failure cardiologist at Scripps Clinic in San Diego. I'm the director of the Advanced Heart Failure program there.
I think the biggest question in the whole field of atrial shunting is how durable are the effects of this device or these kind of devices, and are there any long-term adverse consequences of having left-to-right shunting over many years. And so most of the trials that have been published to date only have 1 year of follow-up. And since REDUCE was the first randomized controlled trial to be published, we now have the longest follow-up of any trial that's out there.
I think the most interesting part of the 3-year data is the fact that there is a sustained response in the responder group. So we saw that effect with respect to a reduction in heart failure events as well as improvements in functional status in the initial follow-up period. But to see that now going out to 3 years is really important. It just highlights the fact that this is potentially a more durable therapy for patients who are suffering from this type of heart failure.
We looked at heart failure events, which were significantly reduced compared to the control group. We looked at how many patients we needed to treat in order to see a benefit. That's something that's called the number needed to treat, or NNT. And so the smaller number, the better it is. So that was how many patients we would have to put an atrial shunt in to prevent one heart failure event, cardiovascular death, or other bad outcomes. And that's actually a pretty favorable number. And if we compare that to the best drugs that we have available to treat HFpEF today, it's actually even better. So if we look at the Emperor Preserve trial, which uses the drug empagliflozin, which is one of the SGLT2 inhibitors that's gained a widespread following for treatment of HFpEF. So this device seems to compare favorably to the best drug therapies that we have available today. Quality of life is really important, and I think many patients would say that quality of life is actually more important than avoiding a heart failure hospitalization. And in fact, people may not even remember that they came into the hospital for 2 days last year to get IV diuretics, but they know how they feel on a day-to-day basis. And so we have this patient reported quality of life score called the KCCQ score that we use in most clinical trials. And if you look at the changes in the KCCQ score with, again, the best medical therapy that we have available today, which is SGLT2 inhibitors, that score improves by 1 to 2 points, and that's on a scale of 0 to 100. And it's generally considered that you need to see at least a 5-point improvement before we consider it to be clinically significant. And we are seeing improvements that are actually much greater than that with the device.
Quality of life is probably the most important thing that patients feel when they're thinking about the treatment regimen that we're recommending to them. For drugs, often it does take some period of time to develop that improvement in quality of life, if patients are able to get to it at all. Anecdotally, the patients that we have treated now over the course of the last several years who have received a shunt, typically that effect is somewhat quick. They're able to notice their improvements, their functional class status improvements relatively quickly.
This 3-year follow-up data is really important because this is what everyone keeps asking is it safe over the long haul? And I think that the data that we have today suggests that it is, and we don't really see any evidence of worsening right heart failure over this time frame.
Additionally, what's important to note is that there weren't any major structural changes that were concerning.
But I think that most of us in the field believe that elevations of left atrial pressure that lead to elevations of pressure inside the lungs is still the common thing that causes symptoms in the majority of patients. And so regardless of age, regardless of whether they have obesity, regardless of whether hypertension is the problem, the left atrial pressure seems to be the single uniting mechanism. So, I think the evidence that an atrial shunt, which doesn't do anything except lower left atrial pressure, helps people, solidifies our understanding of the pathophysiology of the disease, and I think reinforces our notion that the left atrial pressure really is the linchpin in this, and that our efforts need to continue to focus on keeping that pressure low. The other thing that I think is important to remember is that the best drugs that we have for HFpEF today are the SGLT2 inhibitors. And we see really very modest, significant effects, but modest effects on both the hard clinical endpoints, such as the heart failure hospitalizations, where there's about 2 to 3% reduction in heart failure hospitalizations over a course of 3 years, so about 1% per year.
When we're thinking about drugs for HFpEF versus devices for HFpEF, I think both ultimately will be needed. Drugs are there, but they're limited in terms of their efficacy. And we know right now, even as far as what the guidelines are recommending, we don't have any class 1 drugs that are approved for this cohort of patients. When we think about benefits of devices as compared to the drugs, I think probably one of the key features is the fact that not everybody has access to all the medications that we want to prescribe. Sometimes we're limited by what is approved by patients' insurers, and often we're limited by costs because patients, even if it's approved, may have significant costs associated with being able to take certain medications. Whereas with a device, this is sort of a one-time treatment that could potentially offer benefit in the long term.
Medications obviously are easy to take. There's typically not any long-term adverse effects. You can stop taking them, and usually if there is a downside, that effect goes away. People are used to taking medications, and that's considered to be the first choice of how we treat heart failure today. And yet, patients universally don't like taking medications. All of them tell me, I don't want to take them. And is it reasonable to think that maybe we could consider device or mechanical therapies before medications or as a way to get people off of medications? And honestly, that is the thing that probably is most appealing to most of the patients that I talk to about the potential of getting a device like this. And patients really love the idea of a mechanical approach rather than taking yet another pill.